Is Dr. Carolyn Snider, and Dr. Snider is the Chief of Emergency Medicine at St. Mike's Hospital. Dr. Snider's research focuses on the development, implementation, and evaluation of interventions for marginalized and underserved populations. Importantly, Dr. Snider harmonizes her work with a full life outside the hospital and university. She's a very happy mother, wife, traveler, singer, reader, and cook. Tonight, she's going to be talking about gender and medicine in 2019, where we are, where we can go, and how can we get there. So please join me in welcoming to the podium, Dr. Carolyn Snider.
Thanks so much. Do you stay up here, or
You're going to
sneak out? Okay. So I want to start by thanking you for the invitation to come talk tonight, or today. In Whistler, in 2003, I was not invited to UBC for an interview at CARMS, and so I am excited to be here now. I feel like a bit vindicated. Yesterday, however, I did notice all the people who are mountain bikers and the little code brown streak that's quite obvious on their backside, and I thought maybe that wasn't the best place for me anyways. No, I appreciate coming, and it's a beautiful place to be. So I was asked to speak about gender, and I'm going to start. I think it's really important, and I suspect everybody in this room understands that when we use the word gender, it is really not a binary term, although most commonly we do treat it as binary, women and men. And so I want to acknowledge that. Much of the work that I will discuss today does actually hit the binary women and men, but if you can keep in the back of your mind anytime we're talking about this, that anybody who may identify as non-binary may usually will be affected by many of the conversations or issues that we're talking about tonight. Today we're going to talk about, there's so many things we could talk about, but we are going to talk about education, department dynamics, group dynamics, and leadership within emergency medicine. And most importantly, we're going to talk about ways that we can all, and I do think this is an all of us role, be allies in this change, if indeed we think that a change is necessary. So this has always been something that people have been talking about, but in December 2017, the Time's Up campaign really took hold. It started within the Me Too movement, which was in the entertainment field where it was about sexual harassment, but really it moved into understanding gender differences across all sorts of different fields, and healthcare is no exception. When we talk about it, some people find it a very intimidating conversation, both men and women, very, very personal conversations that can occur because of that. And I want to set the stage right now that I want this to be a comfortable space to feel a little uncomfortable in. This is a place that's near me now in Toronto, about an hour away. This is where I go instead of the mountains to recuperate. And I often, when we talk about our happy place, this is my happy place. And when I talk about gender, it's actually for me a very comfortable conversation. And that's what's happened in the last 2 years. It's not something that's sort of been quietly discussed. And that's what the Time's Up campaign has meant for me, is that it's stuff that I've started to awaken to be aware of, and allows me to have the conversation with people that are starting to awaken to it and notice it as well, to make changes in education, in our departments, in our groups, and in leadership. So the first thing is, we're talking about men and women right now, but in terms of females and males, based in 2018 on a CMA, their master file, where they look at their members of CMA, so we know that this may not be as exact anymore because not everybody is a member of the CMA, but you can see the trend that in the younger emergency physician group, that we're getting close to parity. And that's actually not that surprising. When we look at who's gone through the residency programs for emergency medicine, over the last 10 to 15 years, on average, it's close to 50% of those entering residency are female. And that's kind of reflected in this. We definitely see that of our more senior colleagues, that it's a little less parity, but it's an important thing. So what is actually happening in sort of the pipeline or the lifespan of women in emergency medicine. I'm going to actually start and talk about education. So about 50% or more of medical school students are female. I've already talked about the fact that about 50% of the residents are female. But we start to see a bit of a trailing off and some concerns around what's going on in education. So in 2018, the Royal College Stream of Emergency Medicine, Royal College Stream has implemented competency-based education. And my understanding is that the family practice stream is also strongly looking at competency-based education as well. And in that, we have to meet milestones, and we assess a resident based on milestones. So what's happening in that in evaluation is quite interesting. In the states where they've been using it in certain jurisdictions for a number of years, they did a study on 8 emergency medicine programs. And there they showed that while everybody was at the same level at the start, the evaluations really tapered off around the 3rd and 4th year of residency. So by the end of residency, males were 3 to 4 months ahead in terms of having achieved their milestones. Well, this is fascinating. So it's not necessarily in a good reason fascinating, but what's at base of this? So this same group went and did some qualitative analysis of the comments, and it was an interesting piece that it all hit at that 3rd to 4th year, and it was mostly around resuscitation and how women and men were perceived differently in a resuscitation room. So men had very congruent, common, constant feedback about their resuscitation skills. Women's was much more discordant. And I will say that the reviewers of those residents were both men and women that were providing this discordance. So what's at the base of this? Well, the first and probably most common explanation is around gender normative behavior. So the complexity of that is that the narrative of what we expect a good resuscitation to look like, somebody taking control of the room, everybody knows who's in charge, how that is played out is often very gender normative male. But it doesn't, turns out, mean that it's the best resuscitation. And so I know for myself, as a female in residency and early staff life, it took me a while to find my own space in a resuscitation, to feel confident being myself, as opposed to what I was taught was a good resuscitator. And so I'm actually, if anybody's been in the room with me during resuscitation, you may remember, I'm like, I like a quiet trauma. And I still talk at this level. And I feel much more confident when I'm quiet and kind and saying my pleases and thank yous. That's me. But when I was a resident, I still remember the feedback that rings true to this study where people said, that's not showing confidence. So it took a while for me to own that and step back and say, wait, I still actually feel quite confident. And it's all about the outcomes of this. And so there's actually a study that recently showed female-led cardiac resuscitation patients did better. Now, I'm not going to say that women are better than men. That's not what I'm getting at here. But it's fascinating that if we actually think about gender normative behaviors, it doesn't necessarily mean in resuscitation that what we've been taught is right is the best way for our patients. And so this really gets at the idea of implicit bias, what we think is normal, and how we perceive behaviors in an emergency department, in fact, in life. And so implicit bias is this idea that we don't want to think a certain way, but we still have behaviors that act a certain way. And I will share with you a bit of my own experience in that. For those of you that are familiar with this, you may have taken the Project Implicit or the Implicit Association test. And the most common one that's known is looking at black versus white and your implicit biases around people who are black versus white. And it's an easy test, it's free, you do it online. You put your one finger on the E and your one finger on the I, and they associate the speed to which you associate a picture or a word with other words to really reflect your deep inherent biases. Faster associations are deeper implicit thoughts. So I did a whole bunch of these because I've been sort of interested in implicit bias around marginalized populations in the emergence department and how that affects our work. And I did the one on gender, and this was my result. It said that I have a moderate association for male with career and female with family, and here I am talking about gender and emerge all along. And not only that, the time I did this was when I had moved from Winnipeg back to Toronto and left my husband and daughter still in Winnipeg so that she could finish out her school year. And essentially, like, I was the absent parent. My husband was doing like 90% of the parenting. And in the midst, and everybody was supporting my career and moving to support me. So in the midst of all of this actionable behavior, I still have this deep implicit bias that associates that I'm probably supposed to be doing family stuff. And I can tell you the mom guilt is big. The other area that we need to think about for education is around mentorship and sponsorship. Mentorship and sponsorship has been talked about for many years, and many of the programs now in both medical school and residency are setting up formal mentorship programs, and that is important. They help people identify career goals and steps to reach them. Sponsorship is different, and that's where we're missing a lot of opportunities. Sponsorship is when you sort of tap somebody on the shoulder and you say, I think you'd be really good at this. And that's where we're still seeing some difficulties around women being moved into new roles and new opportunities. Some of this comes from informal opportunities. And so sporting events where only certain genders are invited are often informal sponsorship opportunities. I have, having since taken on the medical director role at St. Mike's, have had a lot of fun when colleagues of mine will say things like, well, we were talking about the X-ray callback system after hockey the other night. And I'll be like, oh, interesting. What did you guys come up with? All right, why don't we bring those kinds of conversations to the group, and let's have those conversations there. Decisions and sponsorship and decisions about groups can't be happening in these informal environments where some people aren't invited. It's a male hockey league, I should say. That's the piece to it that's important. So this moves into sponsorship around hiring and who you bring into your group. And now, I want you to think about your last 5 years of hiring into your group. And remember the stat that about 50% for the last 15 years have been women. And if you feel, and I'm not saying, because year to year it varies. I'm absolutely, the right person may be male this year, if that's who you're hiring. But over the last 5 years, 10 years, if you're not seeing that balance, you may want to question, is there some sort of barrier in place that women are choosing not to apply, or we're not hiring? And I think that's the important question that we all should be having. So that's my little prescription for you for the first one. The other one is when you're both reading and writing letters of references, to think about how we may represent the people we're writing about or we're reading about and what we're looking for. So there was some great work in letters of references for medical faculty done out of Arizona, and this was the what do we do with that information. And so they showed that letters of reference for men are 4 times more likely to have mentioned publications and 2 times as likely to have multiple references to their research when controlled for the actual productivity. So make sure you actually mention that across all comers. And when you read the different reference letters, think about that as well. And the other thing, I say don't stop now, because you will see that references for male medical faculty are 16% longer than the females. And letters for women are 2.5 times as likely to make a minimal assurance. She can do the job. As opposed to things like, she's the best person for the job. Keep it professional. Letters of reference are 7 times more likely to mention something personal, something that probably has no relevance to their actual performance on the job. They're also much less likely to use the formal title, Dr. Snider. They'll use Carolyn. Those are really interesting things. Now that I've told you this, if you're reading Carm's letters or you're writing Carm's letters, be aware of them, but it's hard to unsee them when you start reading letters. And you got to stay away from the stereotypes. We all know this, but it's really important. There's all sorts of adjectives to avoid. Some of them can seem really positive, but in large groups, if they're all about caring, compassionate, and they don't talk about skill and knowledge, it often shapes and stereotypes the person that you're doing. So in the hiring process, there are some guidelines, and this is my prescription for hiring. Do some unconscious bias training. It is incredibly eye-opening. It's hard to unsee the biases that you have once you know about them. I suggest the implicit assumption test, despite the fact that it does have some faults to it, but overall it's been well validated. Using standardized review forms. It's not just a gut feel. That's where our implicit biases come in. It's often helpful to have somebody outside your group to come in whose role it is to really look at it from an objective standpoint and make sure that we have a balanced committee as well. Male, female, older, younger, various different talents and interests on that group. So this is, I'm now going to talk about being in the emergency department and some of the implicit biases that many women will talk about. And I think these conversations can be hard, but it's important to stand back and listen and look for them. So I actually like to use this study. This is Sarah Gray. Some of you may recognize or know. She does a lot of talks, and she's a good friend of mine and now one of my colleagues at St. Mike's. This is the trauma room, the resuscitation, and I talked a little bit about my experience and how I run a trauma or run a resuscitation. But I want to tell you a few stories that are very indicative, and I'll bet you almost everybody in this room has either seen it or experienced this. Just last summer, I had a lovely medical student working with me. He was a few feet taller than me. And we came in because we were called in for a resuscitation patient coming in with a paramedic crew that I had actually never seen. And they walked right in and they looked right at him and they started to tell him the story. And this happens all the time, and I'm kind of used to it. Sometimes if I can gauge their sort of sense, I'll be like, over here, over here. But he did it that day, and that to me was a win. He actually went, she's the one you want to be talking to. I didn't have to say a thing. They were embarrassed. I was like, it's okay, let's keep going. We went on with it. And after that, I spoke to him about the importance of doing that. I don't need you to save me, but sometimes it's just the little nudge like, hey, buddy, it's over here. And that was a helpful moment. We also had a great conversation afterwards. I used it as the teaching moment to sort of say, how often have you noticed that happening? It happens pretty regularly for me. Now that you've noticed it, I want you to notice it as often as possible. And the gentle nudge to that paramedic meant that it was a non-threatening moment for them to learn from it. Sometimes when it's really overt and you have to jump up and down, you got to do it with a bit of fun. Now, the other time that it happened was not so fun. We had a patient, and it was last November, I think. It was very close to the time I was leaving Winnipeg. And the patient had a neck cancer and an expanding a mass in his neck. And I think there was, at the end, I think there was this large hematoma that was also involved there. It was a big mess. These are what nightmares are made of, right, as emerge docs. You just can start hearing the stridor. You know this is going to go downhill quickly. We've got him sitting up in resuscitation. He's deteriorating before our eyes. I've got a fourth-year resident on with me, and I say, call anesthesia. Let's get it set up. We have the surgical airway set up beside the bed. Down comes the anesthesia resident. And I sit down and I start writing the note. And so while I'm writing the note, he starts to get the story, and he's just taking far too long for this emerge doc. I'm just like, oh my God, like just let's go. Have you talked to your staff? But I'm doing it kindly. I'm sort of saying, I'm really concerned about this patient. I'd really like to get this patient up to the OR and get an awake intubation done. And he does this. It's okay, we'll take care of it. And I sort of was like, oh, okay. So I sort of do this, and I look at the fourth-year resident I've been working with for a while, and he looks over and he's like, he's taken aback. Again, for me, that's more the win, right? Because it's when people are noticing it, that's the win. So John and I sort of catch eyes, and I was like, and I said, okay, in all my years of emergency medicine, these are the ones that go downhill quickly, and I need us to act faster. He said, I'm sorry, we have this under control. I'm starting to think, who's we? And I realized at that moment he had no clue. I hadn't met this anesthesia resident before. He had no clue that I was a physician, and it was going to be a concern for the patient, right? So I'm starting to say, I stand up, I turn my badge around. I realized that might have been part of the problem as well. I turned my badge around and I said, I just need to be very clear. As the staff physician, I am very concerned about this patient. In all my years of emergency medicine, these are the patients that go downhill quickly. And just as that's happening, in comes his staff who says, Carolyn, it's great to see you. I hear you're leaving, and blah, 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 blah. And this poor resident, I actually felt sorry for him at the end because I had this moment of realizing he's figured out all of this, that he's made the big, buffoon of himself in the resuscitation room right there, because it was such an overt, hand-on thing. What was really interesting, and again, I talk about the wins in these cases, was a week and a half later, the fourth-year resident I was working with said, I wanted to chat with you about what happened in the resuscitation room. And I was like, great, let's debrief about that. That was an interesting experience. He said, do you know that the resident came up to me afterwards? He was A, mortified, and B, he totally clued in to what he'd done. I didn't have to say a thing. And I was like, again, these are the wins, right? As a woman in emergency medicine, these things happen all the time. So sometimes I have to call them out, and I started to in that case. But it's the wins when the junior people are noticing it. So my prescription to you is teach people it and notice it. And let people know you're noticing it, because we all have a role in addressing this. I'm going to touch a little bit on this area. And it's because I actually don't think this is a gender thing. I think this is a people thing, a life thing. But it does often get looped into gender. And so I'm going to talk a bit about the sandwich generation. I'm doing some scheduling right now. I am amazed how often what people write in there is, I need time off for caregiver weekend. So this is who we are. Yes, we have kids' lessons on certain weekends and caregivers on weekends. But thinking about the sandwich generation, we know that when we talk about leadership and group dynamics and people being involved in the governance decisions of our groups and how we practice medicine, we have to have life-friendly scheduling. And so one of that is on the job. I've been in a few different groups now in my career. Some of them are templated out, and then you get your template and then you try and swap them all around. But there's still this mindset that, well, if you have to swap a lot, it's not as committed to the group as if you sort of can try and make your schedule a little more family-friendly for you. And so in multiple of my groups, we have started to look at scheduling softwares or scheduling systems that allow for a lot more flexibility. What is fascinating to me, having been involved in choosing and implementing those, is it all works out. Everybody gets their share of evenings and nights and weekends and days and stuff, but we can do it with a whole lot less stress on our colleagues. We also have meeting times that are often not conducive. We know we spend enough time in the emergency department and off hours that the last thing you want to do is come in at 7 a.m. for your meeting or stay at 7 o'clock for a meeting. There's no joy in work at 7 o'clock in the morning. Unless, of course, you're doing something really fantastic and being a hero, but you're never a hero at 7 in the morning at a board table. And I put this as a board table. I think for most of us, this is what most of our conference rooms would look like, or where we'd have our meetings, but we'll hope for this. And so talking about timing of meetings, the importance of looking at ways to ensure that everybody in the group can participate in our meetings. So we now do Zoom. We don't start before 9:30. If you've done a night shift, of course, you're not expected, but often people go home, have their coffee, get into their PJs, and actually join in by Zoom. All of our late evening people are showing up to our meetings. We have quorum. We've had quorum for 9 months in a row. for our meetings. So that's an important life piece. So these aren't specific to gender, but many people who have other responsibilities find it very hard to be part of governance decisions. So this is important to gender. How many people know about these terms? Procreation? Anybody want to give a definition for that? Oh, you're right, I am missing a manel. Manels are when it's all males on the panel. There's now some, I was just at the FIX conference by the Feminem group, and they had to be careful not to have too many wannels, they decided, so. Because they truly believe gender is for all of us to be discussing. Mansplaining is when you're talking about something and then somebody said, oh, well, let me just explain it in a different way, and you're just like, I kind of knew that already. Appropriations, that's you're talking about something and then you're interrupted. And the other part to that is when you actually will say something, it kind of goes unsaid, conversation continues, and then somebody else says exactly the same thing, and you're like, that was a great idea. And then they go on to that. So the art of amplification. This is what we've learned. There's been people laughing in the room, and some people that are like, that doesn't happen. I really encourage you to watch and listen, because it doesn't happen in every group. I have been in some great meetings where this does not happen, but I've been in some really amazing rooms and amazing meetings to watch it just like textbook happen. And there was one group, meeting group that I went to monthly back in Winnipeg, and I had a male colleague who, we got talking about this, and he said, I'm gonna watch and I'm gonna amplify. And God, did he have fun. And it was so fun because he'd look me in the eyes and he'd be like, okay, I'm gonna do that. And he'd see me say one thing, or my colleague Cheryl say something, and then we wait 5 minutes, and then a surgeon would say something, and everybody would be like, yeah, that's a great idea. And he'd be like, actually, Carolyn just said that. And it was fascinating how often it happens. So there's my prescription to you. Try to amplify your colleagues. Definitely make sure your junior colleagues are being amplified in that room as well. So now something even like controversial, makes us feel uncomfortable. Is there truly a salary gap? Now you just have to read any Facebook post on this and realize this is significantly controversial. And most people will say it's probably not the case in medicine, emergency medicine. Because for the most part, we bill by patient, right? So I'm going to present some data. We don't have good data yet around this. And so the jury's still out, but I'm going to present some data to give you food for thought. First of all, when we look at academics, this isn't emergency medicine right now, but when you look at academics in Canada, and they look at the salaries for professors, they saw a huge pay gap across many of the universities. At University of Toronto, it was a almost $24,000 pay difference per year for their professors, which can, maybe not sound like a lot for people who make a lot of money, but over a career that can end up as up to $700,000 in lost income. So then another group looked at this kind of information and said, what about based on maybe productivity and grants? And they used the NSERC and the SSHRC, so NSERC for the hardcore sciences and the SSHRC for the social humanities, and looked at grant dollars. And even then, just controlling for the amount of money being brought into the university, they saw a gender pay gap. In the US, they've done this in academic medicine, and the difference between male and female academic MDs was $50,000. They're much more likely to be salaried in the States. They then adjusted for things that probably do account for some of the differences in pay: faculty rank, age, years since specialty, how much funding you got. They even looked at the Medicare payments that you were bringing in to give you sort of an indirect look at how many patients you're seeing, the types of patients you're seeing, and graduation from a top-level medical school. And even then, there was a difference of 19, almost 20,000. In emergency medicine, that was about 6,500. So what's going on in Canada? Well, we don't know for sure, but I'm going to show you a few pieces of information. First of all, in Ontario, where they can look at billing, this will not include the AFP group, which is the academic centers. Excuse me. The ratio of average male to female payments was 1.48. And And so most of us would say, okay, well, that's probably because in those cases, men are maybe seeing more patients or working more shifts. And so again, this is comparing apples to oranges, and I acknowledge that, and the study hasn't been done that allows us to take all of the information cleanly and look at this. But interestingly, and this is just the FRCP-EM group that answered the physician engagement survey for CMA a year ago, this is how many hours they estimate that they spend in a week. And the direct patient care without any teaching is pretty much equivalent. The direct patient care with a teaching is pretty close as well. They spend a bit more time in indirect patient care, so I don't know if that was meant to be charting or not. Interesting, they did more research in this group. I think it's important to qualify that only 91 people answered this. But it is an interesting piece there because it may question that narrative that women are spending less time in the hospital. So then the next question is, are we slower? Because that billing is often per patient, and are we actually slower? And we don't know that, but again, it's a narrative. And so I have access to the docs at St. Mike's, and their cases seen per shift, and we do it on these bar graphs. We have this great little sort of compass, we call it, and it gives me, you know, who's ordering how many CT scans in comparison to their colleagues and how many patients come back after 24 hours unexpectedly, and how many ultrasounds and how many of your patients are actually admitted to internal medicine. So it gives me a bit of an idea on quality, and I use it with our emerge docs to help them choose what their CME options or ideas might be or where they might want to work. And here was the fascinating part, is over the last year, the women in our group, and we're 50% women at St. Mike's, are not slower. And in fact, the cases seen per hour were actually higher. So I don't know the answer to this, but we have to be very careful that the assumptions to whether or not people are bringing home more dollars is just related to speed, amount of time in the emergency department. I'm just putting that out there to sort of push back on some of that narrative. I definitely think there's some work to be done there. Finally, I'm just going to talk quickly about leadership. The piece here is that I think we're probably, now that it's been 15 years out that we're close to parity, it's probably still underrepresented. So it's getting late. I'm going to have everybody stand up for a second, if you could. Stand up. All right. You're going to go up and down a bit here, okay? So sit down if you identify as male. Okay. Stand back up. Everybody? Okay. Sit down if you don't hold a leadership position. Good. Sit down if, okay, so this gives a really good number. That's great. Sit down if you don't hold a leadership position that pays money. Okay. See, that's a bit more interesting, right? We still actually are seeing some nice gender parity here, and that's nice. That's nice to see because it's actually not common, and I think that's great. But we still know that in department chairs across Canada, so across the academic sites, it's at about 20%. Department chiefs, there's definitely a subgroup of us starting. I was the first in the GTA, and then Sunnybrook added in, and I know Heather Lindsay is at UBC, and there's definitely some department chiefs in Alberta as well, and definitely in some smaller centers as well. So I think that there's a lot more women being represented in the administrative field. At the Cape Board of Directors, we've just gotten up to 18%. Prior to that, I think there was 2 until 2 years ago. It's been very rare to see a Cape plenary speaker as female. And I want to say how much I've noticed the balance here. And at EM Update, a similar sized conference in Toronto that sort of services the eastern side of Canada. So the question is, why is there still some gap in leadership? It's getting better, especially over the last few years. Some may say, is it lack of choice? or is it actually a choice? And there is a stereotype that it's impossible to have it all, and being told that we have to choose between leadership and our families. I think that we're more and more pushing back against that. When I speak to more junior women, I often talk about the benefit of having some protected days, which allow me to actually be home for dinner with my family when they're now that they are actually living in Toronto. There's also some assumptions around the idea that women might not be interested despite family responsibilities. And so I think this is a prescription. Don't make the assumption that a young person, and I say that men and women that have young children, aren't interested in the leadership position. They often are very interested, especially if it comes with good stipend that allow to have some protected time, meaning that they could do one less shift a month. There is some work in the business literature that's important to know about, that men are more likely to be promoted based on potential versus women based on what they've already accomplished, and that men are more likely to apply for a leadership position when they check off only 60% of the requirements that are listed in the job ad, versus many women will more likely apply once they've actually hit all 100%. Being aware of this when you review the applications. More importantly, being aware of this when you think about who to tap on the shoulder and to tell them why you're interested in them becoming a leader in your group. So I think this is often more of a conversation kind of piece. I look forward to the questions. I'm happy for this to be a conversation outside of this room as well. My prescription to you on being an ally. An ally is somebody that doesn't necessarily lead the conversation, but takes part in helping advance the issue. And so in doing that, I want you to be aware of your own implicit biases, evaluations for students and residents, your resuscitation, especially around their resuscitation dynamics, but also your own and how you view other people's. Letters of references, hiring, life-friendly scheduling, and that's for all of us, meeting dynamics, appropriations, mansplaining, sponsorship and mentorship. Don't be afraid of sponsoring or mentoring somebody who's of a different gender than you. It shouldn't be an issue. Identify informal leaders in your group, tap them on the shoulder, reward them, and encourage them. So again, thank you for being part of a conversation that I just wanted to get started of a conversation. If you haven't had it already, I'm happy to discuss more and looking forward to any questions.